thank you all for coming, and thank you for taking the time out of your schedules to sit on our panel. We really appreciate it. Casey is actually on his way. He's the moderator for this, but let's start with your introductions. What do you do, and any projects that you're working on? So we'll start with Logan.
Oh, shoot.
Since you're the first one here.
My name is Logan Reed. I'm the Director of Prevention and Education Services at the Southwest Behavioral Health Center. And so we provide prevention services for substance use and mental illness for the Southwest 5 counties of the state.
My name is Hayden Coombs. I'm a professor at Southern Utah University. I teach in the communication department. And is like a formal what I do. Nothing as cool as these guys. I'm just kind of there for my students.
Nice. Am I like low riding? I feel
I
like
know,
I'm
like
so
Where's
like
Dad?
looking up to him. There we go.
I put mine up higher, so I feel taller than everyone.
I found it.
I feel like I'm sitting on the floor.
This is better. I feel
feel
better.
better?
Yeah. My name's Cecilia Jensen. I work for Four Corners Community Behavioral Health. That we cover Carbon, Emory, and Grand. Half-time I'm the opioid project coordinator and grant manager. So I manage our grants we get from the state regarding the opioid epidemic. And then my other half-time is I'm a social work intern. I do therapy at one of our rural offices, and I'm finishing up my graduate degree in social work.
I'm Debbie Mavridakis. I'm the Health Promotions Director at the Southeast Health Department. We have 30 health promotion programs that we work on in health education and opioid. We started working in that in 2016, which was, I feel like we were behind the 8 ball because Carbon County was red flagged in 1999 for opioid overdose deaths. So we had our work cut out for us to try and get caught up and at least try and get an even playing ground for the education and the work that we wanted to do. And we also are the only health department in the United States and the only local health department in the United States that has a harm reduction and needle exchange program. We're going on our 2nd year for that. And it's almost like a new baby, you know, moving through that process has been enlightening and just an amazing process to move through. And it probably gave us our biggest insight into stigma.
My name is Kalenia Dempsey, and I work with the Utah Center of Rural Health. I'm the program coordinator. I should start my therapy, so I'm pretty cool here. I came from Utah Navajo Health System as the clinical manager, and then eventually as a mental health program director. So came this way because of my family, but I'm excited to just jump on board on the deep side. So this is a really good introductory to what we're going to do in the future. And this is my program manager, so he'll moderate the rest of the time. If you guys need anything, I'm right here.
Cole is she's over our new project Echo Hub. So when we get that rolling, it'll be Cole that we'll be working with if you're wanting to get involved in that. She's already done a lot for 3 weeks, so she should get a badge for that. Yeah, for sure. Okay, I apologize for being late, guys. It's been kind of a sporadic afternoon for me. I've been trying to catch up with people I haven't seen in years, which is, you know, the nature of COVID, right? How all these people you see on calls but never get to talk to in person. So thank you guys for our panelists that have come together. Great group here. These guys all do awesome work with suicide and mental health issues and different things. And these are the people that I've learned pretty much all I know about substance use from. I don't know Colton as well, or Hayden as well, but I'm sure he'll teach me a lot today. But Logan and Cecilia and Debbie have mentored me quite a bit to learn more about these areas. So I'm excited to have them in the panel today. Just the first question we have for you guys. What do you think causes the stigma that exists in your communities? And how has that changed? And regarding mental health and substance use, like what's causing that and what's changed about that over the last couple of years with the pandemic, if anything?
Well, I think that that particular question has a couple of parts to it, yes. So the causes of stigma are rooted deeply in many things, in biases and prejudices and lack of education, fear, and media. Media is a huge promoter of stigma, whether we know it or not. We're influenced by media. And when media portrays a substance user, drug addict, yes, it's rarely what the reality is. Now, I'm not saying that sometimes that's not the case, but it's rarely a reality. But that's what we think about when we think about substance use or folks that inject drugs. You know, you think that this is the lowest, the worst of what humans have to offer. And I can assure you that's just really not the case, but it is the perception. And when we started working in this program, maybe that was my perception too, right? Maybe that's what I bought into because I had my own fears about the work that we were fixing to start. But I also want to say that what COVID has been able to accomplish, maybe not as well as it could, but it has shined a spotlight on mental health issues. And most folks who use substances have mental health issues. Not all, because we do have unattended addiction because of the opioid crisis that we're in. But they have mental health issues, the majority of those. And COVID has shined a spotlight on mental health issues, just simply in the sense that we do more check-ins, right? You'll see more media. You'll see even more things on Facebook. How you doing? You know, organizations have come together in communities large and small to promote the need to take better care of our families, those we work with, and even our community members. If anything good came out of COVID, that's what it did. It has a long ways to go, of course, but it is giving us the opportunity to come together and address mental health issues, to do check-ins with those that we love. Because come on, whether we want to say it or not, we were all locked down for over a year. And there were probably moments, if not days, that even the healthy of us was wondering, how many more meals can I cook here at home, you know, or whatever we were struggling with. So COVID did that. In my perspective, just a simple, you know, it did shine a spotlight on it. It did make us more vigilant that we need to take care of our own mental health, our family's mental health, and those are the folks that we work with.
To kind of build on what Debbie said too, I think the stigma against substance use really comes from the criminalization of substance use. You know, for years and years, there was the war on drugs, and that created a stigma of, you know, drug use it's a moral failure. You're a moral failure. It's, you know, so this idea that drug use is that and not more from the disease model of this is a disease. These individuals who have struggled for years have dealt with community perception that you're bad and wrong and you're a criminal and you need to go to jail. We can't be by you. We can't look at you. We, you know, we'll call you these names because you're less than us, because you're a criminal, is kind of, I think, where the stigma towards substance use really, really started. In my community, in Debbie's community, we live in the same community. We've been really, you can tell there's a shift in this criminalization attitude with addiction, and it's moving more toward treatment. And so how do we get these individuals connected to treatment? How do we treat the disease and not treat it as a moral failure? And to do that, we've had to have law enforcement come on board and view this in a different way, because they got to the point where they were handling things with substance use that they're not trained to do, or our jails were full of people struggling with substance use, and they should they really be there? Is there other options for them, better options for them? So getting them on board, and it's kind of this slow shift, I think, nationally, also, that we're recognizing this isn't something that people should necessarily be criminalized for. This is something that they need treatment for. And so I think that is really shifting the stigma on substance use in a slow way.
We have, I don't know if you guys know Michael Tinker. He's the Utah's representative for the DOJ. I did a webinar with him, and when it was over, he says to me, "I'm so sorry we didn't wrap our arms around you sooner," because the law enforcement, like Cecilia said, it's been a slow progress, but we're moving towards where law enforcement knows that we have to do more. And you'll hear more and more about, even someday in your own county, in your own jails, where you'll have receiving centers for folks with mental health issues or struggling with substance abuse, and we won't put them in jail. We'll get them the help that they need. And that's been a long time coming, and it'll be a while building, but it's there and it's available to be able to take advantage of.
Yeah, in my experience, I primarily work with our student body with mental health issues. And I believe most of the stigma, at least on our campus, comes from a lack of knowledge or lack of education on what mental health disorders are, what mental illness looks like. Obviously, there's the stigma that it's, you're wrapped up in the straitjacket and the, insane asylum or whatever. And so a lot of it is educating my students on what to look for. And in a way, the last year and a half has been, we've seen a lot of positive changes in just recognizing mental health illness, what to look for, because not a good thing, but so many more people experienced mental health crises over the last few years. And because of that, even if you didn't experience it, your brother, your sister, your roommate did, and you realized, oh, these are things that normal people struggle with, right? And I mean, that's the main part of my work, is just to, like, in my lectures and classes, I'll joke or say something funny like, oh, my therapist told me this the other day, right? And I hear from students all the time, like, I never think someone like you would struggle with this, right? And partially flattered, then partially like, what is that supposed to mean? But I think that's kind of where, the pandemic has almost been good for the stigma, is the more people that have had these struggles, the more people are willing to talk about it, the more people are willing to champion, combating that stigma.
I teach sociology here at DSU, and in one of my social problems classes, we look at a series of research articles that dive into that question of where stigma comes from. And the three main things that they mention, I think the panelists have all covered. They talk about lack of education, lack of experience, and then the language that we use. And that language one, I think, is really important because it is so simple, so subtle. We don't necessarily pick up on it, but like you're saying, even just saying that you see a therapist has an impact on students and their perceptions of what is normal. My students, one of the students brought up when we were discussing this a couple of months ago, a conversation they had been in where somebody used the phrase, Angie is nutsy Fagan. And so they were asking me, what does that mean? Which was a great opportunity to discuss these simple words. And so we talked about, this is a classic example, I'm probably preaching to the choir here, but you've got, first of all, this really derogatory term that we have put on a mental illness. And so just using that automatically casts it in this negative light. And we talked about better ways to say it, a better option being Angie is bipolar, which is better, and yet we're still saying this is everything about Angie, versus Angie has bipolar disorder, which really separates the person from the disorder, establishes it as something that is not permanent or eternal, that can be treated and can be healed from. And, it's really simple, subtle change in those words, but I think that's one of the main sources of stigma is simple language that we're using to cast things in a different light. And I also like you were mentioning experience, and that was another one that the research identifies. If you've never dealt with somebody with a severe mental illness, or you've never dealt with somebody or interacted with somebody with an addiction, I mean, I guess it's probably natural that you're not really sure how to deal with that. But it can also be really easy to be judgmental when you don't know much about it and you don't understand the sources and the impacts of those things. And so I also like that where these are some of the major sources of stigma, they also become automatic solutions, right? You get educated, you increase your experience, you change your language, and we automatically start breaking down stigma.
We'd like to get into some clarifications too, because we've touched on this a little bit, but and I asked this question thinking I kind of know the answer, but what is stigma different between like substance use, suicide, and other mental health issues? Like, how does stigma for each of those different issues differ from one another? And how are they similar? And like, is there a different cause? Like, will Logan's recipe work for treating stigma in any of those areas?
I think that those stigmas, in regards to that stigma, it's just a different population that's being stigmatized with the same aspects of overall stigma. I mean, you can talk about the 5 different structures of stigma, yes, but it just boils down to 2, public stigma and self-inflicted stigma when folks buy into what the public has to say about them. And I think we have the suicide program. We started working in suicide in our health department in 2013, Cecilia, when we had our suicide death rates were 22, which the average death rate for a population of 100,000 is 11. So we're way off the charts, right? And here's the thing with that particular stigma. Suicide leaves you with unfounded emotions when someone takes their life. I mean, you can't wrap your head around it. And then also, folks would rather call the police for domestic violence than that someone's going to take their life. I don't really get, that, but it too is a health issue, yes, a mental health issue. And so for just my experience with it, the stigma is the same, it's just a different population. It's viewed differently, or you don't hear folks that take their life. Most folks don't say those people, right? But they do, classify them with mental health issues that probably can't be treated. It's just, we believe that suicide is 100% preventable. And that just like CPR, you can learn the skills, 3 simple skills to save the life of someone you love.
QPR, right?
QPR. So anyway, that's how I feel. It's the same systematic stigma. It's just a different population.
I think that's a very big question.
We have a little time to talk about it, but I knew it was.
Because I think they are different a little bit, because you have substance use disorder, you have substance use stigma, and I think a lot of that stigma is around the good and bad moral failure, not really looked at as a disease just because of how it's been treated over the years. You have mental health, which has its own stigma in that you had these institutionalizations of individuals. So, the history is you had these individuals who, if they had any kind of behaviors that were out of the norm, they were sent here, institutionalized, and then we don't talk about it, right? We just, and then those closed down. So then you had all these individuals on the streets to deal with, which then led into the criminal justice system, which then leads into the moral, like good and bad, right? And then what was the other one? Suicide. So you have suicide, and that's a whole, you get into religious beliefs about that, and you get into, deeply, so all of these are deeply rooted belief systems that people have And so you talk about, Logan's points of, these are easy solutions. And they look like it, yes. And it does take, it's you plant the seed with things, but it's a process because you're changing very deeply rooted belief systems in communities, in individuals, in society. So it's a big issue that I think we can start with those types of planning and attacking it in that way, but recognizing that these aren't just things that we're gonna talk to the law enforcement and they're gonna change their beliefs. It's gonna take time to really have some internal reflection of what my beliefs are, why are they there, and then the education piece around it of why is it different now, why can I look at this differently, should I look at it differently, and how can I change that? So
Do you guys see different challenges with different age populations as far as stigma is concerned? Like I think about like my parents and grandparents that grew up with the likes of one flew over the cuckoo nest in the state hospital, mental health hospitals that Cecilia is talking about. And in day and age, when somebody had a mental health problem, you stuck them there. They didn't know what to do with them, just stuck them there and left them there. And I can imagine a hospital full of people with mental health issues that are untreated because they don't know how to treat them at that point must have been pretty crazy. So is it harder to get somebody in the elderly community to buy into reversing those experiences versus like college students that you work with that have never experienced or saw those things firsthand?
I think that, so Michelle and I were just talking about this walking up here, the generation, the younger generation are probably more open-minded, of course, but it doesn't mean that the older population can't change their thinking. It goes back to that education and being familiar with something, because the older generation has loved ones that have taken their life. They have loved ones that are suffering with an opioid addiction or struggling to get the right medication for their whatever mental health issue they have. I think it can be learned. I see some separation in it, of course, but I don't think it's impossible to educate them because they're exposed to the same things we're exposed to. They're exposed, right? Yes, and they're exposed to the media and they have their old school thinking, but it can be changed. I think.
I think part of it comes down to the approach. It might be really easy for me to give that example I just gave with language to my young students and have them very easily grasp that concept and adopt it, versus understanding that if I'm talking to somebody from an older generation, there is a much deeper root to the belief system. And there's also a different way that language was being used. For example, you might have somebody who's really used to using a derogatory term referring to a mental illness or an addiction, but they're not necessarily internalizing it as being negative. And so if I just say, don't use this language, that doesn't mean anything to them. So when we're approaching somebody from an older generation, it might require more of an educational process to get them to understand why the language might need to be changed, and then moving into the change system, where with some younger populations, it might be a lot easier to advance through those steps.
And I think it's interesting to look that stigma itself is affected by social and health inequities in different populations. That probably goes back to that first question that you asked us.
What about like you serve rural populations? Are there additional challenges with stigma when working with a rural population opposed to an urban?
no, just kidding. Just kidding.
Yeah, well,
Yeah,
that's,
they're very different.
very different.
Gotta look at my face on the replay of the Zoom. So I was like,
So we have a very conservative, most rural areas are extremely conservative, not just conservative, okay? I feel like I'm kind of conservative, but we're talking conservative, conservative with old school thinking, 1950s thinking in some of our rural populations. And that's a challenge when you are trying to create new programs, you know, affect change, better the health of your community. I mean, come on, in San Juan County, they got posters in their yard saying, we don't want no government help, you know? I mean, they're very, very conservative, extremists almost, and conservative. So I don't know. I think it will change, but rural areas, well, I'll tell you, when I started harm reduction in the middle of COVID, my sheriffs came and told me they were going to have me arrested if I did that. My county attorney put me on notice that I would be arrested, which I'm not sure he could do that because I work at the health department and he's my attorney. But that was the conservative thinking, right? So you're going to do this. Well, watch out. We'll stop you. We'll arrest you. And so that's a tough challenge to change that kind of thinking. And I do know that when we first started harm reduction or even working in opioid and suicide prevention, the urban areas seem to move through those problems quicker than we did for some reason. I don't know. I don't live in urban, you know, areas, but it seems to me that they were able to implement specific programs without as much harshness or judgment. I mean, we got hate mail, we got threatened on Facebook, and I don't know that a lot of our counterparts that worked in those programs can say that. So from my perspective, yes, but I don't work in urban.
My perspective, it's much different. I started in urban, my career in mental health and substance use at Davis Behavioral up in Layton. And I relocated back to Carbon County where I'm from. And so going from, it's night and day different. And you have a lot of the programs, campaigns and things coming from our urban area up in Salt Lake, the Wasatch Front, you know, they're kind of creating these things and moving them down the pipeline. Well, they get to rural and we're like, this isn't going to work for us. This isn't going to work for our people. Our people are not going to hear this message. They're not going to, this isn't going to be effective. And so we really have to be huge advocates for our areas and go back and say, hey, like, we don't have transportation. We don't have a bus system. We don't have,
We don't
we're
have
not
a taxi.
We're not going to get that anytime soon. You know, these aren't things that this grant funding and can be used for. And so how can we do this differently? Because it looks differently for us.
I give you a little example for suicide. So we're partnering. They had these billboards, Provo and up, that I wanted in my community for suicide. And one of them was, you know, to prevent suicide, just ask, right? So I went back to Carbon County and I said, how do I get that billboard here? I had to write a grant for it, so that's a whole different story. But one of the messages that our Salt Lake media company came up with us was that, was for men, because that's our target group. And they just talked about how our men are tenderhearted. Well, that's not going to fly in Carbon County, you know. Our men are coal mine action workers, and right, they're if I play an ad that tells them they're tenderhearted, they're going to make their wife turn the radio off. So but that messaging works in urban, you know. So we changed it to say, under your tough exterior, you know, you have a soft heart, which is true, right? But Cecilia's right. We even have to change the way we message, so that we're not alienating in an instant a prevention message that we want to get across.
Logan, I'm curious your perspective, because you have this 5-county region, and it seems like the further north and the further east you go, the more rural it gets. So you probably see, I don't want to put words in your mouth, but do you see differences in stigma in Washington County versus Eastern Garfield?
You've got to go even more micro than that. I mean, in Washington County, you have the St. George metro area, and then you've got Hilldale, and you've got Enterprise, which are very different communities than the urban center that we have here. And I think it comes down to, you know, you're talking about culture, you're talking about way of life. And so whether that is rural versus urban, or if it's an age group that we're looking at, you're likely to have some differences in the issue. You're also likely to have similarities, but your approach is going to have to be different. The example that you're giving, you know, they're in an urban area, you're going to find a lot of men who feel the same way about don't call me tenderhearted. You might have a broader category that are accepting to that, which is why that message might work. But again, you have to take into account that culture. So depending on your target audience, even within an urban area, you might need to adjust your message the same way that you did. So I think that really you're just talking about culture, various ways of life, and our approach is going to have to match those depending on our target audience.
That makes so much sense.
Colton, you have anything? Or Colton, I keep calling you Colton because I know Colton.
That's all right.
Hayden, you have anything you want to add?
He sounds like a cool guy.
Everybody with the last name Coombs, right?
That's right. So when I started working with my students, I have a brother who's a clinical psychologist in Grand Junction, Colorado. And he was telling me, you know, rural areas do have all these extra trials and issues they have to get over. And he told me to always remember the 3 A's of rural health, or rural mental health. They're accessibility, acceptability, and availability, right? And I'm not going to be able to help my students with all of them, but maybe I can help with one of them, right? But when I think of like the stigma surrounding like how to help my students here versus help my students there, especially in like this area, one of the things I've run into a lot, and I ran into it with my own when I had my own mental health struggles, I have them every day, but when I had it really bad, how many times, you know, I would hear from community members or family members, like, we got to pray about it. Right. And like being able to tell my students, like, well, this isn't something you're going to be able to pray away. I'm sorry, despite what you've been told or taught, you know, and that stuff can help, but that's not where it starts and ends.
Absolutely.
Don't let her.
Yeah.
Logan is on. So I keep thinking a little bit too. So I work in primary prevention. And one of the focus areas for us really is just on the youth. So as you've done different stigma reduction campaigns, how have you made sure that that's still, we do know that youth need to understand that there are consequences, that there are risks associated with specifically substance use in this particular thing. But also risks of not asking for help with their mental health, right? And then that's how we get down into suicide and these different things. And so when you have worked on stigma reduction in your communities and the people you're working with, how do you keep youth right there in the center? Because we know that that's for us, and maybe that's not your center, but I guess that's kind of what my question is.
For us, one of the things that we like to do for a lot of the coalitions that we have is we look for that youth perspective. They have a really good idea on what needs to be done. When we started our suicide prevention coalition, we had a couple of youth from the junior high, and one of the kids said to me, you have to start this in grade school, because if you're bullied in grade school and you live in a rural area, it's going to follow you all the way to high school.
Can't escape it. You're gonna have that bully.
And I didn't even think about that, right? Like, oh, I got to start real young here. So I think for us, having a youth perspective, we do that with our tobacco coalition. They really have some very good ideas. Not only do they have some great ideas, but they're innovative in how to push those out to their peers, peer to peer, you know, they know best, if that makes sense. But it's hard sometimes because you have, well, maybe you have like for suicide prevention, you know, we know we need to start young, but getting into the grade school level is tough, yes. So educating the parents and hoping that they take that home. I mean, we don't have a silver bullet, but what we do have is buckshot. So we just send that out there as far as.
That's our rural language.
I like
We all have a shotgun at home, a buckshot in it.
Probably the only shells you can find these days either.
And Maddie, one of the thoughts that came to my mind, because you specifically mentioned primary prevention and then youth. And we know that one of the best ways to create community level change is with policy. And I think there's really exciting stuff happening. For a long time, we were addressing personal and interpersonal stigma. And the last decade or so, I think we've realized that we also need to include in that institutional stigma. And that's where there's a lot of opportunities for policies that can have a big impact on how we approach or how we interpret things. One of the examples that comes to mind is last year, our state passed legislation that allows parents to excuse their students from school for a mental illness, the same way they would for a physical sickness.
And about time, huh?
Right. I mean, you're talking about a policy that sends a very clear message that says your wellness is important. And just like getting treatment and healing from a physical sickness is important and maybe even worthy of missing school, the same is true for a mental illness. So when you say primary prevention in youth, I think policy is a sector that has to be included in our efforts to create measurable change.
And I think updated policy too, because policy, organizational policy for 50, 60 years has laid the foundation for stigma for mental health and substance use. And we're still fighting against those policies and those governmental laws that stop you from doing what you need to do. So for harm reduction, I can do all the harm reduction I want, yes. But the biggest component for harm reduction is syringe exchange to reduce Hep C and HIV, to ensure that they're using clean needles. But I can't buy them with federal dollars. It's a policy, it's a federal policy. So in order to do that, we beg people to donate to us, or we buy them ourselves. So that's a policy that, an organizational policy that's very, very harmful. And that's just one, right? But policy is beneficial in creating positive change if you can move people's thinking towards what it is intended to fix.
I'm trying to formulate a question to kind of turn us towards the home stretch of this panel, but not quite sure how to formulate it. What I want to know is, you guys have all done a lot of work with stigma reduction. What should the rest of the room be focused on in our efforts to help support stigma reduction? Like where are we at with that? What are some of the successes that you've seen, the innovative things that you've seen, and what can each of the rest of us take away from your panel discussion today on what we can go home and do in our primary roles to help combat that? What are our next steps? What can we support the effort of stigma reduction?
I think he said it best, language.
Yeah. I
Learn
agree.
to change your language. We have a website called Cure the Conversation, and it's just completely dedicated to changing the language, to change the way you perceive a person with substance use disorder, or you perceive a person with mental health issues, to begin to change that language to first person language. And it's not easy, Kay, and we're not perfect, but we are making progress towards that, and to change that institutional language, because even in behavioral health or even in our office, sometimes we slip and say those things, right? So, but to begin to change the language, that's easy done. You can teach that everywhere you go. And it's important, especially for professionals, to provide the language to someone that ensures their dignity. That's what I think.
I think just to add, there's the Substance Abuse and Mental Health Services Administration also has a great little booklet that has a lot of examples of just those simple words and phrases that we use and alternatives that
Yes.
you can use for them. I'm going to go back to, again, I think that the panel has covered these three things, but the language, education, and experience, they're not necessarily simple solutions, and they're they're not non-complex. But I think everybody can find something in that realm that they can do. I had a student one time, we were talking about this very issue. And after class, my student came up and said, I'm realizing, I think this is going back to the education. With the education, he was starting to realize that he has a lot of misconceptions about mental illness and addiction. And he was telling me that he has a brother who is dealing with both of these things, and he has a really hard time relating and therefore a hard time connecting. So he's telling me that they have kind of drawn away from each other because he doesn't really know. And so we were talking about that experience thing. You know, the research shows that when you get experience with these, you understand them better, and thus the stigma, the judgment, the prejudice starts to go away. And so I was asking him about what opportunities he might think of where he could get some experience. What he ended up doing, and this is, you know, to his credit, but he actually came over to our agency and started as a volunteer. And he spent about 3 months just volunteering with some of our groups where he was interacting with people who were getting treatment for mental illness and for addiction. And it was really interesting just to see how quickly that changed his perspectives and how quickly he became comfortable with talking about the issues, dealing with the issues, interacting with others. And you know, in a short period of time, because of that experience that he gained, he was able to reconnect with his brother and no longer have that barrier there. So I think that in all three of those realms, education, experience, and focusing on little things like language, we could probably find something that each of us could do to help.
And there's also, it's called a dictionary that you can look up online, and it has the preferred language for folks that are struggling. It's pretty informative if you think about it. And for shared experiences, when we first started doing harm reduction, I want to tell you that I just thought everybody's house would be disgusting, okay? I know, but it wasn't true. I was so surprised when we would go to their homes, and some of their homes are immaculate, and they're substance users. They inject heroin 7, 8, 9, 10 times a day, and their homes were fabulous, you know, and it surprised me. And why did it surprise me? Because I have my own stigma about it, right? I just have my own perception of what a substance user's home would look like. And I was wrong. You know, it just didn't hold true every time we went.
To agree with the language aspect of it, I think just start to build awareness in your life of where you're saying things that might be stigmatizing, like, you know, as like such as all this weather so bipolar, or just things like that we don't even really consider. Just start to bring awareness around that, and then you can change it, because how do we change something if we're not even aware we're doing it? So just consider that in your life of where that's happening, and what language can I use differently. And then also pointing out too that, you know, we say substance use. Well, the division's name is substance abuse and mental health, right? So having the division change, yeah, exactly, organizationally. So just start shifting that way, because it's not something that's going to happen overnight, and it might be uncomfortable and it might feel weird, but that's how you create change and a new habit in your brain.
I think going back to what you're saying, what can we all do? I think we're all masters and experiences, experts of our own experiences of our own lives. So use those experiences to help people that you know are struggling, right? Like the way I went down this path was after I got to a better place and felt comfortable sharing my experience. I had the school newspaper print my story, how I was feeling, and what resources at SUU that were available to students. And in the next 3 days, I had 22 students that I did never have even had in class that found my office that said, hey, I think I'm experiencing this too, or I think this is what I'm experiencing. So just being willing to share your experiences is, I think, one of the biggest things you can do. And I think that's something substance abuse has done for years, right? With sponsors and people being so comfortable saying, I'm a recovering addict, I'm a recovered addict. It's no different with the mental health side.
This slide up. Colton and I need to, or Colton. I have a peer mentor, I'm dyslexic. I have a mental health issue. I'm just gonna call you Dr. Coons. You and I need to chat about our health.
I'm
our healthy
ABD
T-birds.
right now too, so I'm not even really Dr. Coombs.
You need to come chat with me about a Healthy T-Birds Coalition on campus and what we can do, because it sounds like you've got some pull with your students that could be helpful.
Let's do it.
But it seems like a shame to me that it's probably a societal issue in our country, but you know, the dumbest things go viral. Like, it seems like a shame we can't use that, you know, social media influencers, viral videos and things to change the perception in the language. Have you seen anybody do that successfully? You know, and we know it works for healthcare. Wasn't it the Lou Gehrig's disease that they had the ice bucket challenge for? And obviously kind of got away from the disease and more towards dumping ice on each other. But I mean, we've seen those kind of things go viral. Have you seen anything related to stigma reduction that they've been able to accomplish that with? And is there opportunity there for something like that? Could that be something that pushes the needle a little bit?
I think sure. You can, there's a lot more information about reducing stigma than there ever was before. But we talked about it at the beginning of this. Media has a big role to play. They reach more people than I can reach, or you can reach, or you can reach. And media is important to be able to change the perception of what they promote, because we internalize that.
Yeah, like the media needs to use its powers for good more.
Yes.
often.
We created media guidelines that we want our community to use when they're reporting on an overdose death. And it's similar to suicide media guidelines, but a little different, right? Because they're responsible for getting it right, and they have a bigger reach than we have. And if you can get those media partners on board to support your change, it's important, because before, when people would report on suicide, it was just terrible. Yes, like they committed suicide and they would tell you how it happened, and it was graphic and unnecessary. And the same a lot with opioid overdose deaths. I do know that there was a media company in Salt Lake that reported on an opioid overdose death that could not even ever have happened that way. You know, that the needle was still stuck in their arms when they died on the park bench, you know. No, that needle's gonna fall out. So getting them on board because again, they have a bigger reach than we have. And when we sent our media guidelines to our 3 counties, I was pleasantly surprised that they would try and adhere to that.
I also think it's difficult because maybe on the larger scale, it might be different, but you know, thinking of like your day-to-day stuff, all of us on our smartphones with our apps and things, like we all have an algorithm, right? We all have whatever we look at is the media that's brought to us. And so if we're not looking at that, that media is not gonna, it's not gonna come to us. And so I don't know how to like kind of like branch out from that to, I don't know, that's tricky.
Yeah, I mean, I think when I get on Instagram and I'm just like looking at meme pages and stuff, the ones that make me laugh the most are the ones that deal with anxiety and depression, because that's the stuff I deal with the most. And I, you know, can see the humor in the situation, and I'll get on and share it or whatever, post it on my story. And I'm always surprised at how many of my students will like react to it laughing, or with the heart, or with the hands clapping emoji, you know. And like, that's not my students telling me they think that's funny. Maybe they do, but that's a sign that, okay, I need to text this guy, hey, what's going on? You good? Hey, you know. And like, how many great conversations have come from that? So like, yeah, they're using the wrong language in these memes, and it could be offensive to the wrong, yeah, but also there is good that can come out of it. It can start with that laugh, or, you know, we laugh because so we don't cry. That's what I always say to my wife. So, yeah, I mean, once again, just going back to normalizing the conversation.
And I had a completely opposite scenario where I was working in suicide prevention in my area, and And I was an advocate, right? I was online, I was on Facebook, I'm like sharing everything and anything, and it'd get 1 to 2 hearts, 1 to 2 people in my life who are surrounding me are scrolling past it. But I share a picture of my kids, there's like 200 likes, And so I'm like, well, wait a minute, why aren't you hearing that other message that I'm trying to share with you? Why aren't you, that's the important message. You need to hear this message. And so I think part of the solution is learning how to send the message in a way that people will hear it, whatever population we're working with, what message do we need to send that they'll hear, and considering that in the process.
But humor is important when you touched on that, because if you all remember on 9/11, no one could talk about anything until the national comedians started making fun of it. They started adding humor to it, which helped America move through that painful process. This is silly, but we were going to try and create a campaign, that when you got milk, like you got mental health problems, try to find a way to make it normal. This is what we have without dehumanizing it as well. It's just hard.
Well, I think it's interesting. You already broke it down between like substance abuse, mental health, and suicide. There really is like they're in 3 different stages. When someone's sharing something about substance abuse recovery, we're all standing up, clapping, we're excited, we want to help them. Mental health, we're getting there, but it's still kind of like, all right, it's going to take a bit. But like suicide, the only people that know anything about suicide are those who have lost loved ones to it and those who are experts in the field. And it's almost like we still don't know how to react to it. When someone shares those resources, it's like, gosh, I'm glad those resources are out there, but we're still uncomfortable with it.
We're down to what, 2 minutes. Okay, so maybe just any final comments?
I just want to thank you guys for being interested in it. I think, when you're interested in it, you'll find a way to move it through with what you do. And this panel's amazing. I'll take them home with me. Well,
I'm-
Cecilia's already gone. So.
I'll be right behind you on the highway.
You can't take care of it. I keep looking.
No, I'm taking
Keep them close
it.
by. I'm gonna need Hayden up at SCE, so you can't, they gotta. stay.
You mean Colton?
No, no.
I'm just kidding.
gotta-
I know.
You got it right that time.
I know, I'm totally
That's
kidding.
so good. No, I would say my one thing was like, I wouldn't have made it through my big struggles were it not for my wife, because she had already gone through that. And there's a lot of people out there that don't have someone like I did to make the appointments for me, to drive me to the meetings and whatever. But we can all be that person, right? And it's not hard at all. And it's actually a really cool experience to be able to do that. So just be that person.
And try
Even just someone to support you while you're doing it.
Right.
A lot of people don't even have that. They don't even have friends.
Right.
I went-
Or they do, but their friends have never talked about it,
Yeah,
right?
there's no one to do with that, yeah.
and just try to come from a place of understanding. What somebody might say something that is offensive to you, but their whole experience in life is much different than yours, and just try to come from a place of understanding of where that's coming from. And then we can work together. I think we can kind of partner better. That's my opinion.
All right, guys, we'll wrap up this panel. Get the panel. Have a 15-minute break, and then we'll have our last panel discussion.
Hey, Casey, I'm gonna take Ashley's award home. Is that all right?
Logan, I have a question.
When we get done, there's not another panel in this room. So there's only 2 panels in the last session, so, and they're back in the other building.
Oh, this is yours right now. I haven't seen this.
This is yours, Hayden.
You know the.
That was so good. I was hoping it'd be like, right, cool.
Find it out right.
Thank you, guys.
Yeah, I have a peer mentor.
Or does that not totally apply? 'Cause it's- it's-
I worked with all last year, so I see Coons and my head just goes straight to Colton. That's the only Coons I know.
It's funny how we say what we know.
Mental association.
One of the guys my wife dated while I was on my mission was named Colton. So my mother-in-law has called me Colton many times over the years. And I'm like, come freaking on. She dated him for like 2 months. Still remembers his name.
She's stuck in her memory.
That's right.
Thank you, Casey.